Good afternoon, everyone, and welcome to today's presentation, High Value Care, Finding the Balance Between Benefit, Risk, and Cost. My name is Cindy Eisman, and I'm going to be your facilitator today. At this time, all attendee lines are muted for this session. To minimize background noise and distractions, we do this for all of our webinars. We do encourage your questions, however, and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will also include polling questions, and we encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our Health Vision's Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar, and you'll find instructions on how to navigate to the YouTube channel and subscribe in the handouts for today's meeting. Today we're privileged to have three speakers, and at this time I would like to introduce each of them individually. First, we have C. Jessica Dine, MD. Dr. Dine received her medical training at the Ruth and Raymond Perlman School of Medicine at the University of Pennsylvania, and subsequently completed her residency, chief residency, and pulmonary fellowship at the hospital of the University of Pennsylvania. She received her Master's of Health Policy Research during her fellowship training, and she is currently an assistant professor in the Division of Pulmonary, Allergy, and Critical Care. She is also an associate program director for the Internal Medicine Residency Program. Dr. Dine's clinical focus is on consultative pulmonary medicine. Her education role focuses on the development of robust evaluation systems and improving residency training related to high-value care. Her research interests include measuring the development of practice patterns during medical training and understanding the factors that influence that behavior. Next, we have Sabir Roof, MD, who has served as the chairperson of radiology at Jamaica and Flushing Hospitals in Queens, New York since 2001. She helped create a team of 20 board-certified and fellowship-trained radiologists that provide patient-centered care at the two hospitals. Recently, she was appointed Chief Medical Officer and Patient Safety Officer for Jamaica and Flushing Hospitals. Dr. Roof has received several grants from Avon and Susan G. Komen for breast cancer education and outreach. She sits on the ACR Commission on Patient and Family-Centered Care, and her passion is to promote patient-centric healthcare. She's working with CMS on the Transforming Clinical Practice Initiative and serves as the national faculty leader for this project. Finally, we have Nancy Fredericks, MBA, who has been on staff at the American College of Radiology for 15 years, where she supported the ACR's Medical Imaging Clinical Trials Research Program for over 10 years. She transferred to the college's Quality and Safety Division to work with the team on the development and deployment of the Radiology Support Communications and Alignment Network, or RSCAN, a program focused on improving the ordering of imaging tests that are of high diagnostic value for patients. RSCAN is supported by a grant under the CMS Innovation Center's Transforming Clinical Practice Initiative, and Nancy is the RSCAN Program Director. For our agenda today, we're going to cover our material in 4 sections. We're going to have an overview of high-value care and then a case study of high-value care in action presented by Dr. Dine. And then we're going to look at appropriate utilization of imaging with Dr. Roof and appropriate utilization in action with Nancy Fredericks. We like to start our sessions with questions to run on, things that we want you to be thinking about while you're listening to this presentation. And these are some of the questions to run on that we think today's presentation will help to answer for you. What are the types of tests and treatments common to my practice that have potential for overuse? What tools are available for me to understand and address overutilization? How can local medical culture and defensive medicine sometimes impact our decision-making? What are strategies and processes we can use to educate patients, families, and referral sources about appropriate use? What are processes I can use in my practice to improve patient safety and outcomes by reducing the use of unnecessary tests or treatments? How can cost savings from these reductions improve the overall health of our delivery system? And finally, how can my practice contribute to the overall TCPI aim of saving the healthcare system $1 to $4 billion over 4 years? That is one of the key aims of TCPI for all of our PTN practices. And we want to be starting to think a little more about how, on a practice level, we can help to address that aim. So we're going to launch our first polling question here. I'm hoping we can see it. Launch, 1 second, launch. Okay. So we have our first polling question up. Just take a moment to read the question and respond to one of the answers that you see. Okay, have about 56% voting. We'll wait a few minutes. Okay, we have about 72% of the group voting, and this is what our responses are to this point. 54% say yes, we have identified and are addressing opportunities for overutilization within our practice. 23% said yes, we've evaluated but have not identified any opportunities to work on. And another 23% said no, but we are interested in doing this. That's great. We're coming into this with a lot of momentum then for people already starting to look at the process, taking action on it, or having interest in wanting to do a little bit more. So at this point, I would like to hand over the controls to Dr. Jessica Dine so that she can talk to us about high-value care. So give us a second here. And Dr. Dine, you should be able to manipulate the slides at this point.
Can you help me get back to the slides?
Not there, huh?
I still see the quick poll.
Okay, sorry about that. How about closing it? Okay, now can you manipulate the slide? Yep.
Got it. Great. Thank you very much. So you already heard my introduction. I just want to first say thank you for inviting me to talk to you today. I really appreciate it. And the only thing I want to add to my introduction is that I collaborate with the American College of Physicians. And what I do with them, I really help create educational material for physicians like all of us online and other healthcare providers to help us do high-value care. And my goal here today is first to convince you that this is important and we should all be doing our part to provide high-value care, but then give you a taste of what free resources are available on the ACP website so that you can, after this webinar, go out and access them. So what is high-value care? Well, our definition of high-value care is that it's really any patient care that tries to improve patient outcomes. And it does that by balancing the benefits and harms of a test or an intervention with the cost of that test or intervention. And I think in medical training, we're really taught a lot about how to know the benefits and harms of something that we want to order, but we're not really taught about how to incorporate cost, or to be quite honest, I had no idea where to even look up what something might potentially cost. So we tend to talk a lot about the cost piece because we're uncomfortable with it, but high value care really is, cost is just part of the definition. So why is cost so important? Sorry, there you go. As you all know, healthcare costs are rapidly rising in the United States. It was actually flattening off for some time, but now is rising again. And if you look at sort of what is driving that increase in cost, about a third of it is actually considered wasted care. And the definition of wasted care is that it is care that doesn't provide any benefit to the patient and in fact can be harmful. And so if you were to eliminate that 30% of wasted care, you would either have the same patient outcomes we have now, or it would actually improve outcomes. And for those of you that aren't visual learners, this slide just kind of puts that in words. So another way that we always hear about this is that healthcare spending is rising 2.4% faster than the GDP. It's always termed that this is unsustainable, and what they mean by that is that, you know, it's taking away money from other areas, and we can't just spend it all on healthcare. And the 30% translates into $765 billion of healthcare waste. And unfortunately, us physicians, we're responsible for a lot of that waste. So we need to be part of the solution and help figure out how to choose this, how to do that. So when you look at what is this wasted care, some of it is totally out of our hands. So there's there's administrative costs, there's inefficiencies in our system, then some prices are just higher than what it actually should cost, and there's fraud. And that fraud isn't just physician fraud, there's payer fraud, there's patient fraud. Those are really not under the umbrella of high-value care, but high-value care deals with this big bucket of unnecessary services and the smaller bucket of missed prevention. Because to do high-value care, you try to prevent harm, so it really focuses on prevention as well. And when you look at what are these unnecessary services made up for, everything is, we're ordering more of everything, but what's really driving that rapid increase is imaging, which is that line at the top here, and tests. And we're spending more on other things, but those two things are really the biggest buckets under the unnecessary services. So the ACP developed a framework. Well, how do we address this? How do we practice high-value care? And it's a 5-step framework. The first step is really just understanding what are the benefits, what are the harms, and what are the costs of the intervention or the treatment that I'm considering for my patient. And on the website, and I'll walk you through this a little bit more in later slides, are ways to kind of figure out what the costs are. Once you know the benefits, harms, and costs of whatever you're considering, you basically eliminate any of them that are harmful or aren't going to provide any benefit. That leaves you with hopefully several other things you could do, interventions or treatments, and that's when the cost effectiveness piece comes in. You choose the one that provides the biggest benefit with the least amount of harms and the least amount of cost. So that might actually be the most expensive test, because if the most expensive test gives the most benefit to the patient, that's the right answer. But if you have two tests that have about the same benefit and one is cheaper, then you would pick the cheaper one. The fourth step is incorporating your patient in these conversations. They should be part of this, and they should know what cost is coming their way. The fifth step is really starting to think about it on a system level rather than just on individual patient interactions, and I'll show you some resources on the website there as well. So if you just Google ACP High Value Care, you'll be brought to the High Value Care website. And there's 3 main buckets. There's resources for clinicians, there's resources for educators, and there's resources for patients. I think I've looked through all of them. They're all really helpful to daily clinical practice, but the one where you might want to start out with is the resources for clinicians. Within that bucket, you'll find high value care cases. Those have been recently updated in January of this year. And I'm going to give you an example of one of these. You can complete these, and they have both CME and MOC credit. And as of Friday, will also be MOC credit for the medicine subspecialties. In the curriculum, or in the educational bucket, there's a curriculum that was created by the ECP that comes with PowerPoint, with facilitator guides, with handouts that you can download for free. It was originally created for residents and fellows, but I've used them to educate myself and to educate faculty, and they're a wonderful resource to get an introduction to this topic. There's also high value care cases for medical students, and there's videos from a seminar that the ECP put on about high value care quality improvement projects. So that's sort of thinking about the step 5, how do you do this on a system level? They videotaped each of the lectures that day that give you the basics of quality improvement, and then with a particular spin towards high value care quality improvement projects. There's also videos about how to talk to patients about this. So a lot of times when we get feedback from clinicians, they tell us that the patients often want to get testing as well. And so the Choosing Wisely videos are really based on the Choosing Wisely list and provide communication guides via the video on how to talk to patients. So for example, there's a video about how to talk to a patient with low back pain about imaging for low back pain. There's the High Value Care Coordination Toolkit, which gives you resources on how to communicate between providers, so the PCP with a specialist and the other way around. And as you guys know, there's also ongoing training in this that you guys are a site for. There's a transition toolkit on how to improve the transition of pediatric patients to adults. And then under the patient section, there's some information for a collaboration with Consumer Reports about how do we talk to patients about this and how do we give the patients the tool to talk to physicians about cost. So what I'm going to do now is I'm going to give you a little bit of a taste of the high value care cases. I think they're wonderful. They're a great learning opportunity. We won't have time to go through all of them. We won't even have time to go through one entire one, but I'll give you sort of a taste. There's 5 modules. They would take you about 30 to 60 minutes to complete. Each of them comes with take-home tools. So for example, the first one, the Eliminating Healthcare Waste, has links to where to look up costs, average costs for tests and treatments in your area. And some of them even you can put in the patient's insurance company, and it gives you sort of an average of what part of that cost the patient would see. The second module talks about how does insurance impact patient outcomes. The third one was called Cost-Effective Cancer Screening, is now called Cost-Effective Diagnostic Testing. It still includes cancer screening, but also expands to other diagnostic testing. The fourth one is high-value care or high-value hospitalization. And the fifth one, which is the one that I was asked to sort of dive into, is how do you overcome some of the barriers to providing high-value care. Each of these modules starts with a clinical vignette, and then there's multiple choice questions based on that clinical vignette. After you answer them, you then get the answer to why that was correct or incorrect, and sort of the key takeaway points with links to the take-home tools. So I'm going to give you a taste of the fifth one, the barriers to high-value care. You guys are obviously on this phone call thinking this is important, and what we've heard from a lot of healthcare providers is, yes, we think this is the right thing to do, but it's really hard to do. And so after the ACP surveyed its members, after talking to experts and practicing providers, the ACP identified some common barriers to practicing high-value care, and this module tries to give you some tools to overcome these. So some of the most common ones are discomfort with diagnostic uncertainty, and related to that, sort of practicing defensive medicine. There's also about how do you talk to the patient, because the patient may sometimes be the one driving, asking for testing. And then how do you communicate with other clinicians? We've heard from some clinicians saying that even if I do it, they can see someone else, and then that test gets ordered. So I'm going to dive into case 2 of that one. So this is patient Melissa Evans. She's 34. She's otherwise healthy. She's never smoked, and she's coming in because of bothersome allergy symptoms, and they've gotten worse over the last 6 months. So she has the classic symptoms. She has rhinorrhea. She feels the postnasal drip. She's coughing, but she has no systemic symptoms, no fevers, no chills, no weight loss, and no headache. And on exam, her exam is pretty unremarkable, except she has these injected nares. She has some minimal maxillary sinus tenderness, and you can see the postnasal drip on oropharyngeal exam. Again, no red flags on her exam. She has no lymphadenopathy. She has clear lungs. So you really think that she has allergies. But you've already treated her for allergies. She's been on antihistamines. You've added inhaled nasal steroids, and she hasn't gotten any better. She's even gotten a course of antibiotics for this possible sinusitis, and hasn't gotten any better. So you decide you're going to send her to an allergist. Sorry, I lost control of the slides. But when you order the allergy consultation, you get a pop-up that says, anyone who's coming to allergy needs to be seen by ENT first. And so you feel a little uncomfortable with this because you really think this is allergies. You're not sure that having her see ENT really helps. So what should you do next? I think we have a polling question coming up with this. Just give us 1 minute to pull up the polling. So what would you do next? Would you give her another course of antibiotics, and if she doesn't get better, you order another sinus CT? You call the allergist that you referred her to and talk about whether or not she really needs to see an ENT first. You keep giving her the nasal steroids and see what happens, or you send her to ENT. So what would you do? Cindy, I'm going to need your help with this one. I don't see the results of the poll.
Oh, I'm sorry, Dr. Dine. I'm reading them to you. I was on mute. We have 75% of the respondents responding, and 0% said they would attempt another trial. 73% said they would contact the allergist to discuss the need. 0% would continue the nasal glucosteroid, and 27% would order the otolaryngology consultation.
Perfect. Thank you. So the right answer for this particular case is to call the allergist and talk to the ENT, like most of you said, talk about whether or not she really needs to see ENT, right? So that is easier said than done. I mean, those of you who voted for that, you think that, you know what, she doesn't need an ENT. I really think this is allergies. But we're all busy, and we can't call every single person that we refer to. And so it might just be easier sometimes to order the ENT consultation. And so that is a barrier to providing high-value care. And so the key point here is that there's local medical culture that really sometimes makes it hard for us to practice high-value care. And so the point of this particular module is to help you identify that local medical culture exists. It usually happens because of what we're used to, where we trained, right? So often this happens before there's good evidence. So for example, when I started training we were all taught to do very extensive pre-op testing, and now we have data that maybe this extensive testing isn't necessary, but a lot of us still do it because that's what we were trained in. And there's actually research that shows that where you've trained sort of imprints on your practice patterns, and it's sometimes hard to let go of those patterns. And so one way to overcome this is to really just focus, like to really speak about it. Cindy, can you advance the slide for me?
I did. Did I get it?
Thank you.
One more?
No, that's good. What these modules will do is not only help you identify the barriers that you probably already know about, but then how do you overcome them? So if you look at the literature review for local medical culture, the things that have been shown to be effective is to bring it up, like really talk about this. So at the next practice meeting, how many of you have encountered that when you refer to an allergist, your patients need to see an ENT? What do you think about that? And then if available, bring the best available evidence from the medical literature showing that, if someone doesn't have any of these other red flags, they don't need to see ENT. And then it has been well documented in the literature that if you have a respected clinical expert as sort of leading the practice change, it really helps buy-in. So you don't even need that clinical expert to give the talk or be at the meeting, but if you have a flyer having his or her picture on there, really helps. And then something that drives physicians is comparative data. So if you have any data on variations in care and whether or not that changes outcomes, that is really helpful. For our residents, we actually give them their average daily labs compared to their peers on that service, and that really drives them to start looking at whether or not their practice, whether they're ordering too many daily labs. So you end up talking to the allergist. She doesn't end up seeing ENT. She goes straight to the allergist. And the allergist decides to order a CT scan and tells the patient that rarely this is a sinus malignancy that presents this way, and so we need to get the CT. And there's sort of this overtone of the allergist doesn't want to miss it, doesn't want to get sued. And so the patient comes back to see you and asks, do I really need this test? I'm really scared about the radiation associated with CT scans. So we're going to have another polling question about which of the following is the most accurate reason that some physicians obtain defensive imaging? Is it that the physician believes that the additional testing, the cost of that extra sinus CT, is decreased by the cost of the medical legal practice down the road if you were to miss sinus disease? Or is it that if you get the CT scan to rule out the sinus CT, you're less likely to get sued? Is it that we as physicians tend to overestimate the likelihood of very rare catastrophic events? Or is it well documented that subspecialists really are at higher risk for liability, so at an allergist it makes sense to order the CT?
We'll give it a second to get a little more voting. We're at 30% right now. We're at 50. We'll give it a few more seconds. I like to get to 75 if we can. Okay, well, with 60% of the participants weighing in, 0% said that additional testing is balanced by decreased medical legal costs. 58% said that excluding uncommon conditions, I'm going to read the full text. Imaging, they chose imaging to exclude uncommon but potentially serious conditions has shown to effectively decrease liability costs. 17% said that the physicians overestimate the likelihood of rare but potentially catastrophic events, and 25% that subspecialists are at increased risk for liability compared to primary care physicians. So 58% actually chose B. That was the top vote getter, if you will.
Great. And I think that sort of mirrors what a lot of physicians believe, that if we get this testing, that we're less likely to get sued because we've ruled out these rare catastrophic conditions. It turns out that that is actually not the case, and it hasn't shown to decrease your risk of liability. In fact, we tend to overestimate the likelihood of rare but potentially catastrophic events. And so this, again, the key point here is that we tend to overestimate our risk for liability. That tends us to order tests, but it shows that it hasn't actually decreased our liability. And just as it'll go through sort of the definition of defensive medicine. It's not just ordering a test. It might actually also be steering a patient away from a high-risk procedure because we are overestimating the potential for adverse events from that procedure. It adds to a lot of cost in our system, and a lot of that could be prevented. And so what the module will walk you through is all the evidence behind the fact that we tend to overestimate this, and that there are lots of good data available showing that defensive medicine doesn't decrease your risk of liability. So getting that CT scan isn't going to make it less likely that that patient will sue you. What the data shows is that actually clear and empathetic communications with the patients is what will reduce your risk for liability more than anything else. And I would just add that documenting it will also be very helpful. So this module will then walk you through, well, how do you have these communications? So thank you for letting me give you just a taste of one of these modules. Please go check out the website and get free CME credit and learn something about high-value care. Thank you for your time.
Thank you, Dr. Dine. We really appreciate your time today, and I'm sure we will be making really good use of the high-value care cases on the ACP website. I'm going to turn over controls now to Dr. Sabia Roof, who is going to present the first part of our presentation from the American College of Radiology. Dr. Roof, can you control the slide?
Yes, I think so.
Okay. All right.
Okay. All right. Good afternoon, everyone. And I first want to thank you for providing me an opportunity to participate in this webinar today. Dr. Dine, that was a great presentation. I think we all now understand why it is important to avoid unnecessary tests, especially imaging tests, which make up a significant portion of our healthcare spending. So the topics that I'm going to be covering today are the American College of Radiology appropriateness criteria and their role in promoting appropriate utilization of medical imaging. We'll discuss the use of appropriateness criteria in clinical practice. After that, I'm going to discuss a little bit about the imaging clinical decision support and our experience at the Medicis Health Network. I'll briefly touch upon the Pama Act of 2014, or the Protecting Access to Medicare Act. And finally, my colleague, Nancy Fredericks, will be discussing the RSCAN project. So during the 1990s, American College of Radiology recognized the need to define national guidelines for appropriate use of imaging technologies. So in 1994, a task force was created. Evidence-based guidelines are now developed to assist referring clinicians make the most appropriate imaging or treatment decisions for a specific clinical condition. These guidelines help providers enhance the quality of care and contribute to the most efficacious use of radiology. At the current time, we have about 230 imaging topics and clinical conditions with over 1,100 variants that we have this guidance for. I think I'm sorry, Cindy, this is, okay. They're just, I think the slides are just going on without my control.
I stepped away,
okay.
So you should
now,
have...
Yes, now, I think now it is, yeah, now it's okay. So when we employ these guidelines, it gives the providers the maximum benefit of performing imaging, medical imaging, radiological procedures, and minimizes the risk of harm to our patients. We are able to eliminate unnecessary procedures, and we are able to eliminate inappropriate utilization. From the beginning, the task force for the appropriateness criteria has relied on a combination of evidence. And when we don't have the data from scientific outcomes, we have the expert consensus. And the intended use of these appropriate criteria is for educational purposes and for clinical decision guidance. So if a clinician is considering an imaging study, what is the study or the studies that are most likely to provide the necessary information for that diagnosis? Input of physicians from other medical specialties is employed to provide important clinical perspectives. And we have a list of 22 other professional societies, and representatives from these societies are part of the panels when we are coming up with the appropriateness criteria. There is a defined process how these criteria are created. For an appropriate criteria development, first, systematic search of scientific literature is performed. Then the guideline authors assess the literature, identify the articles to retain and remove. The authors then update and create the topics and the variants with imaging procedures or treatments. Then there's a larger panel that reviews these articles and recommendations and carries out rating rounds. And once that is done, the topics are then created, and every 3 years, the topics are updated or more frequently if needed. So here's what happens. So once the ratings are provided by the panel, the dispersion of the individual ratings from the panel median rate is assessed to determine if there is no disagreement. So the category definition, where the imaging procedure or the treatment is indicated in the specified clinical scenario and at a favorable risk-benefit ratio for the patients, the category name is usually appropriate, and we give them the ratings of 7, 8, and 9. If the imaging procedure or the treatment is unlikely to be indicated in the specified clinical scenario, or the risk-benefit ratio for the patient is likely to be unfavorable, then it falls under the category of usually not appropriate. So it's very low scoring, 1, 2, and 3. But when the individual ratings are for the panel are too dispersed for the panel medium, which may be, then it goes under the category of may be appropriate, and the imaging procedure or treatment may be indicated in that specific clinical scenario or an alternate to imaging procedure or treatments with a more favorable risk-benefit ratio. So it's defined for that clinical scenario, and we give those ratings of 4, 5, or 6. Here's one of the topics that you will find in the appropriate criteria is low back pain, something that an indication that is really imaging is abused for. So this is one of the topics, and you will see under this topic there are 6 variants. So it will tell you if the back pain is acute, subacute, or chronic, uncomplicated, and no prior management, then this is what you do. Or variant 2, if it is acute, subacute, chronic, uncomplicated, low back pain, but patient has history of low velocity trauma or osteoporosis, or is an elderly individual, or is on chronic steroid use, then these are your recommendations, and so on. So when the sample table for that variant comes up, it tells you which study is the most appropriate. So if you see for this patient with low back pain, with new or progressing symptoms or clinical findings, with a history of prior lumbar spine, MRI of the lumbar spine with and without contrast has the highest ratings because it can help you differentiate a disc from scar. The last column tells you how much radiation is associated with that exam, which for MRI there is none. And then after that, your second choice would be the CT lumbar spine with contrast, and it tells you in the comments why that is so, and so on for all the studies that can be done for low back pain. These appropriate risk criteria can be accessed on the ACR website, and if you go to the basic access button, then it will list all the criteria all the appropriate risk criteria that are in place. And then as you click on each criteria, then you can go into more detail about the ratings of the various tests and the evidence behind that. So let me now go into the imaging clinical decision support. And our experience at our hospitals with the ACR Select. So an imaging clinical decision support is a platform that will deliver appropriate use criteria, such as the ACR appropriateness criteria. ACR Select is a clinical decision support platform that delivers the American College of Radiology appropriateness criteria content along with the appropriateness use content from other medical organizations. It can be integrated into your EMR. We have it integrated with our EPIC system, and is also available as a web-based portal. And here is an example of what the clinicians will see. So it is integrated into your EMR, which in our case is EPIC. As the clinician is ready to order an exam, they will put the patient's information in there. They will put the clinical history and signs and symptoms. Then different clinical scenarios will come up. If the patient has low back pain, which one fits your patient's profile, they will click on that, and then will pop up the screen where it will tell them which is the most indicated test and what is the cost associated with that test and how much radiation is associated with that test. So this gives the clinician an opportunity to make an informed decision about what test to order for their patient. Another example for a 66-year-old patient with acute renal failure, and when the clinician puts the studies to be ordered, this will give them the list of studies, the ratings, in this case the ultrasound of the abdomen being the most appropriate. It will give them the cost associated with that test, and will also give them an idea of how much radiation. Since ultrasound is associated with none, there is no So again, very, very helpful for the clinicians to make an informed decision about what test to order. We implemented ACR Select in our 2 hospitals only on the inpatient side initially in 2015. And after the first 6 months, when I ran the report, we found out that a majority, 60% of our studies, the clinicians were bypassing the ACR Select piece, because at that time there was an option that they could bypass and just enter the clinical history and not have to deal with ACR Select. So at which point we had to stop that bypass. We stopped the bypass, so they didn't have an option and they had to go through ACR Select and make their choices. And then I ran a report in 2016 after having the system running for a whole entire year. And we realized that about 62 to 63% of our studies are in the appropriate range, which is rating of 7 to 9. We had about 23% of our studies in the maybe appropriate, which I still consider appropriate, in that 4 to 6 range, and only 10% of our studies are now in the low appropriateness or 1 to 3 category. So this was very helpful. I can further drill this data down to individual physician level and can then figure out if any one physician is ordering in a low appropriate range all the time, and which would then lead to a discussion with the appropriate chair of that service so we can educate the physician. Also important was another report that we can get out of the ACR Select. It is called the Impact Report. It tells me that when the patients order through ACR Select and they are given a choice, 85% of those physicians proceeded with the ACR Select order. 2 to 3% of those orders had to be changed. But more importantly, 12% of those orders were completely canceled. Now, I cannot at this time tell you whether in the future they went back and they ordered that study, but if I take that 12% and I assign a dollar number to the number of studies that were canceled, it leads to a saving of about $100,000 for us. So I have a polling question here.
1 second, and I will launch that. So I believe we can see that. How helpful do you perceive the ACR's criteria are to guide discussions with radiology colleagues about optimal imaging? And if you would just select one: not very helpful, somewhat helpful, very helpful, extremely helpful, or uncertain, need more experience reviewing the criteria. And we will see where we're at. We have about 33% voting. Let's try to get that to 75 at least, and then we'll report the scores. Okay, so we have 0% saying not very helpful, so we like that. We have 20% saying somewhat helpful, 53% very helpful, 27% extremely helpful, and 0% uncertain. I'm going to close that. Dr. Roof, I was going to just comment too that I was really impressed that you really completely flipped, 360 degrees or 180 degrees, I guess, the appropriateness versus the non-appropriateness scoring there once you made that a mandatory requirement within the system.
Yes, and when I gave that report at my leadership meetings throughout the hospitals, now everybody is more willing to extend it further. So now we have opened it up to all our outpatients, and now soon going to be launching it in the ER. So, numbers are very powerful. When you show them the numbers, then everybody is more willing to do it. So lastly, I will just touch up on the Pama Act of 2014, which is the Protecting Access to Medicare Act. CMS will soon require physicians to consult specified appropriate use criteria prior to ordering advanced diagnostic imaging services in order for the furnishing provider to receive Medicare reimbursement. And documentation of the appropriate use criteria consultation will be a condition for reimbursement to the imaging physicians. And it will help us eliminate the need for pre-authorizations. So where do we stand now? With the proposed rule from 2018, it looks like the start date will now be January 1st, 2019. And for the first year, it's going to be an educational and operations test period, which means the clinicians would order the appropriate use criteria and the providers would report the appropriate use criteria consultation information on the claim. But the CMS will continue to pay the claims whether or not the correct information is included. So the first year will be more educational. There may be a possibility of doing a volunteer reporting starting July of 2018, but we haven't really heard much about that yet. Also important to say that ACMS has also named ACR as one of the 11 qualified provider-led entities to specify appropriate use criteria for advanced diagnostic imaging, which means the American College of Radiology appropriateness criteria and hence ACR Select will fulfill the need for the appropriate use criteria consultation requirement. And with that, I finish my presentation, and I think Nancy will now move on to do the RScan piece.
Thank you so much, Dr. Roof, for joining us today and presenting that information. I think it was really eye-opening and enlightening for the participants.
Thank you.
So Nancy, can you control the slide? You can. Good for you.
I can. Good. Thank you, Cindy. And
Sure.
all the good information that Drs. Dine and Roof have presented, I think really gives particular relevance to the RScan program, which I'll cover briefly here. But just greatly appreciate the opportunity to present an overview of RScan. And it really is a good way to check out the ACR appropriateness criteria and CDS technology that Dr. Roof just covered in her presentation. But by and large, RScan is about communication between referring clinicians and radiologists to improve imaging care, to reduce avoidable or low-value imaging, and also to reduce associated healthcare costs. Also, I'll mention up front that one of the best aspects is that it is a free resource for all clinicians engaged in image ordering. But just briefly, RScan focuses a collaborating team on improving imaging care based on one or more choosing wisely topics. For example, imaging for low back pain, uncomplicated headache, minor head trauma, and pre-op x-rays. Just those imaging exams for which we know there is considerable overutilization. Oops, I went one too far. Let me... Can I go back here? Oh, there it is. Okay. Thanks. So I think that just to give a flavor for how the RScan program works, I'll profile the experience at Baylor. They were one of the first facilities to carry out an RScan project, and they pursued the imaging for low back pain topic with primary care colleagues. And it was at clinics that serve patients primarily insured by Medicaid. And the lead radiologist, Christy Lincoln, led the retrospective review of 100 low back pain cases that were ordered by clinicians at the primary care clinic. And through this review, they found that there was a good opportunity to improve how imaging for low back pain was ordered and also to reduce the number of exams. So in RScan, we use CDS technology in a novel way. As Dr. Raouf explained, in the clinical setting, it is used to guide image ordering at the point of order. But in RScan, we're using CDS to rate the value of cases that have been ordered retrospectively. And so as you use this tool, it enters data into the RScan database, and it provides quantitative information for a collaborating team to review reports and to share performance on ordering patterns, with colleagues, hospital administrators, and even insurers. And okay. So Dr. Brian Reed was the primary care clinician who led the collaboration, and he saw participation as a way to assess the clinician's ordering patterns, and I think more importantly, really to engage in an education collaboration with radiology. In the Baylor experience, the radiologists were invited to participate in a CME series to present information about image ordering for low back pain, and then also they provided clinicians with a wide variety of educational materials, and many of those materials are available on the RScan website. And Cindy, can you just forward the slide for me? I think I've lost my arrows here. Thank you. And through the Baylor results, the team was able to significantly reduce the ordering of low-value exams. As you can see, 100 exams were reviewed at baseline using the CDS tool, as I mentioned, and then after the educational collaboration, another 100 exams were reviewed, and they found that there was really a significant reduction in the ordering of low back pain. And I'll mention here that to date, we have over 150 practices across the country that are carrying out RScan. And while Baylor certainly was a large facility, we've got practices where there are just 2 and 3 physicians working together. So it really scales from small practices to very large practices. And I'll also note that we're working currently with colleagues from the Delmarva PTN to implement RScan collaborations at several healthcare systems in Delaware. So it's been real fun to work with the team in getting RScan collaborations going. And so all of the tools and resources needed to participate in RScan are on the website. Again, it's open to all. We'd love to talk with more people about participating in RScan, but we really intend to make our website a sort of one-stop shopping so that you can complete a project from start to finish. Also, I'll just mention that of the educational materials that we offer, a number of them have free CME associated with them. We're just launching a new imaging order simulation activity that allows clinicians to get on and just test out their image ordering knowledge and to access clinical decision support as part of the process. Next slide. There it is, okay. So if interested, we have a great team to provide support for getting RScan collaborations up and running. We can present trainings and webinars to referring practices and radiologists. We'd love to help reach out to clinicians to build collaborations. We've got lots of materials that, that we can share. So if this project is of interest, we'd love to hear from you and help you along the way in completing a project. So Cindy, that concludes my remarks.
Sure. Appreciate it. I'm going to take this back now, or I guess I don't need to. All right. So I really do appreciate all of the input from our presenters today. It was a lot of information that we shared and a lot of food for thought as to how we can go back with our practices and work with them on identifying things that might be opportunities for us to help not only provide better care, but provide less costly care so that we are really providing that high value care within our community. So these are our requests and offers as we conclude our session. You know, from a request perspective, the PTN is really asking all member practices to identify at least one test or treatment that has potential for overuse and assess their current performance. Maybe you'll find that you aren't really overusing. but maybe you'll find that you are, and then we can help to help you identify best practice, evidence-based practice, and any clinical decision support that might be helpful for your practice to implement in addressing any overuse issues. We'd also like to ask practices that identify potential for improvement to work with us to create that solution so that we can help you track and provide performance data on those improvements and cost savings through the TCPI program. We do have offers to make. So our practice advisors for the PTN practices will continue to be providing one-to-one support with your practices to complete your transformation projects. And these are just many, one of those many projects that you can work on with your practice advisor. ACP does have their free high-value care case studies available. We provided the link on this slide. So by all means, make that available to yourself to work on your projects in the future. And from an ACR perspective, practices can either enroll in RScan by contacting Nancy, and they can learn more at the rscan.org site, where you can even look up the basic information for just informative purposes if you're not yet prepared to enroll in RScan or start using an ACR Select program. So questions. We were right at the hour, but I have one question if I have Dr. Dine, Dr. Rosto on the line that I would like to throw out there. If there are any others, you can put them into the chat box or raise a hand if you wanted to ask verbally, and I'll unmute your mic. But if you put something in the chat box, we will be sure to get an answer to that question and get it out to all attendees via email. So our one question is, what resources do you find most helpful to educate patients on appropriateness? We often have patients who request testing that might not be appropriate, and we do want them, to both do the right thing and meet their perceived needs.
So, Cindy, in my department, I have posters of something. Joint Commission has the Speak Up posters. And those speaker posters, there's one specific one that is for radiology, and it talks a little bit about the radiation and the different types of studies that are available. And I put those posters in all my areas. I give them the opportunity to speak with the radiologist whenever they want to. So I have my radiologist photographs with their subspecialties listed in the waiting area. So patients, if they have a question, they can ask for a particular radiologist. Also, there is a great resource that the Radiological Society of North America has. It says Radiology Cares, and that is designed specifically for patients so that they can go on and they can read about the procedures that they are having.
That's great.
I would, this is Jessica Dunn. I just want to add that the Choosing Wisely campaign also has patient information. So they have sheets you can print out, and the patient can also go on the website if you don't have time to have the conversation.
Okay, right. So that's right. They have the patient focus. They not only have the clinician focused explanations and education, but they have the patient focused ones.
Correct.
Yes.
Thank you both for that. I don't see any other questions in the chat, and I don't see any hands raised. So being that we are right at the top of the hour, I want to thank everybody for attending today. I hope that you found this session informative. Before you sign out, if you want to download the handouts, they're on there. And in the meantime, we will do a follow-up email to all registrants. So thanks again, and we hope to talk with you all next month.
Thank you.
Bye.
Thank you.
Okay.